And now it gives me great pleasure to present Dr. Hoda Shehata from Alexandria, who is going to discuss exactly what we were talking about now, the difficult task of congestion in heart failure. And this is a really important issue. In America, sometimes they have catheters floating in people's pulmonary arteries, and they're Bluetooth enabled, but in Egypt we don't have that.
Yes.
We only have our clinical sense and other measures that we're going to hear.
Yes.
And heart failure is all about congestion. So we're all looking forward to your presentation, Dr. Hoda.
Thank you, Dr. Henny. Good afternoon, dear professors and colleagues. It's a great pleasure for me to participate in this great congress about the advances in heart failure. My talk today about the integrative assessment of congestion in heart failure throughout the patient journey. First of all, I have nothing to declare. To describe the problem, actually the patients with heart failure often develop congestion that may require urgent hospitalization, especially if the patient has pulmonary congestion or edema. Development of congestion leading to heart failure decompensation is a powerful predictor of poor patient outcome. And increased intracardiac filling pressure often occurs silently and preceding the appearance of congestive symptoms by days or weeks. So unfortunately, 50% of the patients admitted for acute heart failure are discharged with a residual congestion, possibly due to an absence of a clear congestion strategy. Such residual congestion at discharge is associated with increased risk of rehospitalization and death within 6 months after discharge, independent of the underlying pathology. So here there are multiple tools for the quantification of the congestion: the clinical tools and scores, biological markers, imaging tools, and finally the pressure hemodynamics. First of all, the clinical signs and symptoms, which are the most common presentation and cause of hospitalization in our patients. In the 2016 ESC guidelines, they described the most common symptom, the dyspnea or sopnia, PND, and signs also the presence of congested neck veins, third heart sound, and systemic edema. However, physical congestion can only detect moderate to high level of congestion and skip mild degrees of congestion, whether pulmonary or systemic venous congestion. No single parameter from the clinical history or physical examination can detect the underlying hemodynamic change that leads to congestion. So relying on one clinical single parameter to identify decompensated heart failure has low sensitivity and poor predictive value. So dyspnea, this is the most common and cardinal symptom in patients hospitalized for heart failure and in patients with pulmonary congestion. Faster dyspnea relief, which is the target in our patient, associated with better short-term outcome. Dyspnea usually is quantified according to the common and famous NIHA classification. Also, there are orthopnea and paroxysmal nocturnal dyspnea. Both are important indicators of poor outcome in heart failure patients. However, there is absence of a standard methods for orthopnea or PND quantification till yet. Also, the presence of jugular venous pressure elevation or by congested neck veins. It occurs usually in sitting or semi-sitting position, and it usually occurs in patients with right-sided heart failure. In patients with biventricular heart failure, jugular venous pressure predicts the high pulmonary capillary wedge pressure more than 80 millimeter mercury with an 80% accuracy. However, measuring the jugular venous pressure is usually limited by obesity and presence of respiratory pathology like pleural effusion, which is common in our patients. So application of multiple clinical parameters raised the issue for the development of clinical congestion score. The earliest, and it was developed by Stevenson. It's actually a classification, not a true score. And they divided our patients into 4 profiles. Profile A, which is dry and warm. Profile B, the patient is wet and warm. Profile C, wet and cold, and profile L, which is dry and cold. And they have found that profile P and C, the wet patients, are having increased risk for death, suggesting that congestion more than hypoperfusion is a driving poor outcome for our patients. Another score was developed in 2000, which is the Lucas score. It's very simple, but it's qualitative. Usually, it's used for assessment of the patient from 4 to 6 weeks post-discharge. It includes assessment of orthopnea, the congested neck veins, edema, and if the patient has increased diuretics during admission or increase in the body weight during hospitalization. And the score also can predict the 2-year survival rate. If it's 0, the patient has 13% mortality, and if it's 3 or more, the patient has 60% mortality at 2 years. Also, there was another recent score in 2004, which is the Rohde Score. It includes orthopnea, the congested neck vein, the rails, edema, and also if the patient has SS3 gallop. It's easy, bedside echo. It's a powerful predictor for a 6-month mortality. And if it's more than 3, there is an increase in the 6-month mortality rate by 25%. And the most commonly used in the guidelines, which is the EVEREST score, it's done part of the EVEREST trial for the vasopressin antagonist, and it was developed in 2003. It includes assessment of the dyspnea, orthopnea, the congested neck veins, the rails, edema, and finally the fatigue. Usually, it can be used for assessment before hospitalization and during hospital admission and predict the mortality after discharge from hospital. If the patient has a score more than 3, there is an increase in 10% absolute risk of all-cause death in our patients. The second tool, which is commonly noted in the guidelines, which is the biomarkers, the biological markers commonly used, which are the natriuretic peptide. The natriuretic peptides are actually released from the atrial or ventricular myocardium as a part of the stretch or increase the filling pressure inside the chambers. It's a good sensitive method because if you have a normal natriuretic peptide values, most commonly your patient has a probability that patient is a heart failure patient is unlikely. The most commonly used, which is the N-terminal pro-BNP, and this is a standard. If the patient has less than 300 picogram per ml, this means that the patient is not your heart failure patient. And so also it's used in the trials like in sacubitril valsartan assessment. Also, do not forget to look at the renal and liver function test in your patient. Worsening renal functions can be a marker of congestion and can indicate that the patient should have adequate decongestion therapy. Also, there are other causes of renal dysfunction in our patient, and don't forget about the overdiuresis or dehydration of your patients after intensive decongestion. And you can use the ratio of blood urea nitrogen to creatinine to assess if your renal dysfunction is due to congestion or due to dehydration. Also, the liver function test as a part of the systemic venous congestion, usually there is increased pressure inside the hepatic vein, which is impair the liver function. So careful monitoring of the bilirubin and liver enzymes is important in our patients. The most important and rising now, the imaging stars or the imaging tools. First of all, which is the chest X-ray, despite it's still till now the class 1 indication in the guidelines, but in our patient, 20% of the patients admitted with acute heart failure, the chest X-ray is nearly normal. And in another study, they have found that the patient with pulmonary capillary wedge pressure more than 25 millimeter mercury, 40% of them have normal chest X-ray. Let's go for the transthoracic echocardiography. It has a big role in the assessment of congestion in our patient. First of all, in the classification, if your patient has a heart failure with reduced ejection fraction or mid-range ejection fraction or mildly reduced, or finally, your patient has a heart failure with preserved ejection fraction. Also, in the recent study about how to diagnose heart failure with preserved ejection fraction that was published in the European Heart Journal in 2019, they included 2 criteria for the diagnosis of heart failure with preserved ejection fraction, which is the functional and morphological criteria, and the assessment of the septal and lateral velocity using the TDI, also assessment of the left atrial volume, the GLS, and the left ventricular mass index. Also, the echocardiography has an important role to assess the etiology of acute heart failure. Like in our patient here, this patient has an extensive anterior myocardial infarction, which is complicated by apical aneurysm, and there is interventricular septal rupture at the apical segments. Also, this patient, again, another patient with neglected and non-revascularized anterior myocardial infarction, and there is complete free wall rupture of the apical segments into the pericardium, forming a pseudoaneurysm. Also, this patient presented to our department with acute chest pain and was falsely diagnosed as acute coronary syndrome. However, in the echo, we have recognized that there is a dissection flap inside the aorta, complicated with severe aortic valve regurgitation. Also, this is one of our successful patients in our department. This was a pregnant woman. She was coming to our department complaining of acute dyspnea. And during the screening, the echo, the patient was hypoxic before in the ABG analysis. And we found that there is a thrombus on the bifurcation of the two pulmonary arteries. So this patient of acute pulmonary embolism, and she received successfully thrombolytic therapy and improved totally after regarding the hemodynamics and the echo too. Also, do not forget to look if the patient has a pericardial effusion, large pericardial effusion or tamponade, and look at the transmitral respiratory variations. Also, this one of our patients, this is a mitral valve infective endocarditis. The patient suddenly developed acute pulmonary edema, and there is perforation of the anterior leaflet of the mitral valve. And the second patient to the right, this is a patient with fibroelastic deficiency, a rupture posterior chorda tendini, and severe mitral valve regurgitation. Echocardiography has an important role to monitor your patient during admission, just by doing a bedside echo to assess the size of the IVC diameter, and also the collapsibility with inspiration is important. So echocardiography remains the gold standard for assessment of the blood volume and filling pressures before discharge, and it's superior to clinical scores to predict readmission, even comparable to the natriuretic peptides. Let's go to the second rising star here, which is the lung ultrasound to assess the wet lung. Lung ultrasound is an aid on transthoracic echocardiography, just like the lung auscultation as a part of the physical examination. The cumulative increase in the imaging timing is less than 1 minute if you are looking at the pleural water and the lung water. The pleural water, I mean the pleural effusion, and the lung water, which is the pulmonary congestion. A wet lung detected by the lung ultrasound predicts impending acute heart failure, decompensation, and may trigger lung decongestion therapy. When we look what is the value for the lung ultrasound? Recently, if we looked at the lung water cascade here, initially the first event at the top of the curve that there is increase in the wedge pressure or increase in the left ventricular filling pressure, and this causes impairment or disturbance of the Starling balance at the alveolar barrier and increase in the intra-alveolar pressure, causing increase in the blood, in the water inside the alveoli. However, you can find that the lung ultrasound can detect the B lines or the pulmonary congestion in asymptomatic phase of pulmonary congestion. And then later on come lately and very late, the crackles or the dyspnea or the pulmonary congestion at the end of the curve. So the pulmonary congestion is the key manifestation of impending acute heart failure, despite that the clinical and auscultatory and chest X-ray are very late, insensitive, and unspecific sighting for pulmonary congestion. To do a bedside lung ultrasound, we have different protocols. The blue protocol, which is a qualitative and very simple, just by putting the hands of your patients immediately below the clavicle. We have two anterior regions on the chest, and the other image, we have the posterolateral part to look at the pleural effusion. Also, we have other quantitative methods, like dividing the chest into 28 sides or 8 or 4 sides. The normal pattern that we have along the sliding with A lines, the A lines are artificial horizontal artifacts parallel to the pleural line. A lines indicate that we have air below the pleural line. However, when we look for pulmonary congestion, we have to see the B lines. The B lines are described normally as a comet tail vertical artifact, start from the pleural line and it moves with the lung sliding. The degree of congestion depends on the number of the B lines in every intercostal space. This is a patient done by our dear colleague, Dr. Wen and Dr. Mohammed Sakhawi. They are an excellent residents at our department. This is a 55-year-old man. He's a smoker, presented with chest pain 10 days ago, and he started to complain of progressive dyspnea 3 days before admission. As we can see, we have an extensive anterior myocardial infarction, and we can see that there is apical akinesia, even aneurysmal formation. There is a large pericardial effusion, but there is no echo signs of tamponade. Downward, we can see that we have multiple B line indicating that the patient has significant pulmonary congestion. So lung ultrasound has a diagnostic rule in the recent meta-analysis of more than 1,900 patients. The P-profile identified the cardiogenic origin of dyspnea with 85 sensitivity and 92% specificity, superior even to the presence of pleural effusion, and can be compared to the cardiac natriuretic peptides. Also, they have a therapeutic option or therapeutic rule that they can track the dynamic changes during the hospital admission and monitor the diuretic therapy. And it's persistent and pre-discharge or a clinically stable patient is predictive of heart failure, hospitalization, and death. Finally, the decongestion targets at discharge of our patient. EVEREST score is less than 2. NIHA functional class is less than 2. You have to have more than 30% drop of the anti-Pro BNP during the hospitalization, or discharge level of BNP less than 250 picogram per milli. Hemoglobin level should be more than 10 gram per liter, and IVC diameter should be normalized, and you have less than 30 B lines. So our take-home message: evaluating congestion heart failure is as complex as it's crucial. Okay, thank you. مش مشكلة. Okay. So our take-home messages for today is evaluating congestion is heart failure is as complex as it's crucial, and its timely, effective treatment can improve the outcome. The presence of multimodal congestion assessment scores are available now, so it should be applied in an effective manner in each stage of the patient management cycle. The presence of EVEREST cycle natriuretic peptides, which are commonly used together with assessment of the plasma volume variables, can be useful to assess congestion during hospitalization. Lung ultrasound can be added to the bedside transthoracic echocardiography. It's easy to use, free of radiation, provides rapid results, and may be practice-changing tool in the pre and in-hospital management of our patient. A wet lung detected by lung ultrasound predicts impending acute heart failure decompensation and can trigger lung decongestion therapy. Thank you so much.
شكرا هدى. بالراحه والنبي. ممكن هو ربنا كرمنا بكام واحد معيد ومعيده بس زي الفل بصراحه، بس مشكلته في السرعه يا عمرو. يعني انت وجودي عبد الرحمن مالكوش حل ثلاثات. لا عامله كلام كتير بس عايز وقت بالراحه.
تمام.
طبعا انا كله تمام، سكور تمام. دلوقتي انا لسه بتكلم مع هاني على اللانج الترا ساوند. احنا متعودين سماعه من زمان، حط سماعه مش سامع ايام بينهج، يبقى العيان ده ما عندوش الفيولار بلمونري اديما، عنده انترستيشال بلمونري اديما. انت كده جبتي الانترستيشال بلمونري اديما صح؟
بالظبط باللانج
يعني
الترا
انت
ساوند.
يا سلام، انا ممكن مش عايز لو انا سمعت بيزل او 100 زونال مش محتاج الترا ساوند، ده وقته العيان بينهج هعمله ازاي يعني؟
بالظبط.
بس هي دي التكه بتاعت اللي هو احنا ده كنا بنكتشفه ازاي؟ انا ساعات عيان يجي العياده او في المستشفى اقول له بعدين انا بص انا شاكك فيه بالرغم ان هو بريزيرفد، اقول له روح اعمل اكس راي يلاقي كونجيشن رهيب، ما انا مش سامعه بالسماعه وما عنديش لانج. انت كده بتقولي لنا ان في طريقه ثانيه لازم تبقى تريند عليها صح كده ولا انا فاهم غلط؟
احنا بقينا ويل تريند، في كتير من الويب شاطرين
يعني
عندنا في موضوع اللانج
حاجه اللي هو الاي والبي لاين. على فكره في الكوفيد ايرا الالترا ساوند كان اكتر من السي تي
بالظبط،
بس احنا في مصر ما عملناهاش. يعني البي لاين انا قعدت قريت زمان في الاول على الموضوع ده، بس استغربت ان كل بتوع الصدريه ما بيطلبوش. يعني السي تي تعرضه جامد جدا، مع ان اللانج الترا ساوند اسهل واحسن وسيف، مجرد مسقطك وتشوف العين. دي الجزء الاولاني من ده. الجزء الثاني انت دلوقتي اخر سلايد ممكن نجيب لو سمحت اخر سلايد بس اللي انت اللي قبل التيك هوم مسج، بس عشان انت خدتيها بسرعه عشان الوقت هيخلص، لان هي دي اللي بعد ما قلت الكلام ده كله الناس كلها تاهت منك صراحه. يعني انت ما تهتش بس انا شايف وشوش كلها تايه. طب مين عايز اخر سلايد؟ لو كله فاهم انا همشي، انا مروح. لا اهو بص بدا يرفعوا ايدينا وكله عايز السلايد اللي قبل الاخير قبل التيك هوم مسج اللي حضرتك عامله فيه جدول.
تمام.
ممكن بالراحه تقول لنا الجدول ده البيتونه بتاعت القصه كلها بعد اذنك يعني.
تمام.
قبل ده اي بص في بتاع كده جبتيها وطنشتيها اللي قبليها، جبتي الصوره كده وطنشتيها ما قلتيش عليها حاجه خالص.
ما كانش
ايه طب جايبها ليه؟ دي جايبها لي دي. طيب دي فيها ايه دي؟
فاضل 1 minute. ما دي بصراحه فيري امبورتنت سلايد على كانت بالظبط في الجاك كانوا هم قايلين ان البيشنت قبل الادميشن ايه البارامترز اللي انا اعملها او السكورز اللي استخدمها، وديورنج هوسبيتاليزيشن وافتر ديسشارج.
ايه يعني هعمل ايه؟
اول حاجه اللي هي تو ذا ليفت لو انا عندي هارت فيلير بيشنت ويتش سكور استخدمه لستيفنسونز، يعني انا احدد الاول بيشنت بتاعي ويت يعني هو congested ولا hypoperfused من الاول. ده simple classification. This is not a score.
point of care ممكن تعملي تعمليه
ناتريوريتك
واللانج
بيبتايد.
التراساوند وايكو، يعني حطي ايكو شوفي
بالظبط.
الاي بي سي واعملي لانج التراساوند واعملي برو ام بي واعملي له كلاسيفيكيشن.
بالظبط كده.
بعدين
بعد كده
هيروح
السايت
الإسعاف.
هيروح الاي ار. هاسس البيشنت بالايفرست سكور.
طيب.
خلاص ده الموست كومن اللي هو في 2013 هعمل له فول لاب اللي هو
يطلع فوق كده هيعمل اشعه صدر ولانج التراساوند وكدني وليفر وخلاص.
بالظبط. بعد كده during hospitalization هلاقي هنا مش موجوده الناتريوريتك بيبتايدز. ناتريوريتك بيبتايدز ار يوزد اونلي بس قبل الادميشن، ده عشان استراتيفاي البيشنت بتاعي ده الديسنيا اللي عنده secondary to heart failure or not.
تمام.
وبعملها after discharge بس for risk prognosis. اشوف البيشنت هل suitable يبقى discharged ولا ريسك عنده increased risk for rehospitalization.
ايه البلازما فوليوم دي بقى؟
نعم.
ايه استيميتد بلازما
ما
فوليوم؟
دي كنت شايلاه وموجوده، هي دي في تو فورمولا شتراوس فورمولا، دي باساس according to hematocrit and hemoglobin level of the patient، ودي بتبقى done at the initial admission and before discharge عشان بس monitor for the plasma volume level during admission يعني.
جديده دي.
تعرفها
دي؟ استيميتد بلازما فوليوم بروتين
هي موجوده بس عامله لها هايد.
طيب ما انا يعني
خبيتها
ان انت يعني حاجه تقيله دي. طب هنا في حاجه ثانيه زياده علينا هنا ولا عشان
لا هم نفس السكورز.
Thank you very much.
Thank you دكتور.
يعني يا بخت طب اسكندريه بحضرتك وبالتيم كله.
Thank you لحضرتك.
وهستأذن زميلي الدكتور ياسر صادق لانه انا على المعاش بس هو اكتف في معهد القلب ان احنا نقدم طلب رسمي لطب اسكندريه نمرن الناس بتوعنا بتوع الامرجنسي روم والانتنسيف كير على البي لاينز واللانج التراساوند. We have some deficit دي حاجه بس I think we can learn it لانه
with pleasure طبعا. اتفضل.
معلش تاني عشان الحته دي هي is very important بالنسبه لي. يعني الرول of the focus
yes
البوكيت التراساوند او الايفن البروبر ايكو في انهي جزء، يعني هل البيشنت ده حضرتك بتعملي له اللانج التراساوند لان في مصر البي ان بي مش بالسهوله زي بره اسهل حاجه عندهم، بتعمليه قبل تحليل الانتي برو بي ان بي ولا بعده جنرالي يعني في البراكتس بتاعك؟
في احنا في بصراحه اكشوالي يعني ان اور هوسبيتال الناتريوريتك بيبتايدز دول مش بنعملهم روتين فور ذا patients because of the cost and it's expensive. Usually we admit the patient based on the clinical symptoms, on the history of the patient, doing chest X-ray, the lab, and doing a comprehensive echo assessment. And if we have seen during the transthoracic echocardiography that we have a multiple B lines and there is normal lung sliding, this is a heart failure patient. If we have absent lung sliding, this patient may have some sort of pneumonia or chest infection.
زي عيانين كوفيد
yes بالظبط.
Okay, thank you. Just for the record يا بروفيسور على ذكر الكوست بتاع الانتي برو بي ان بي. I have overcome this by buying a point of care machine by the company the only company which discovered the anti-pro BNP, and the cost for each of our patients is just less than 50 Egyptian pounds. We have the cheapest and we get the result in 5 minutes, very accurate result. فهو المعامل مع احترامنا ليهم بيشتغلونا لان التست دي بتوصل في مصر 500 والافات، التست ب 50 جنيه. فاي مكان عايز يشتغل هارت فيلير all you need to do is to get a point of care machine شريط زي شريط السكر and you get a very accurate result. Thank you very much.
Thank you.
Thank you
دكتور.
excellent presentation. أنا بس برضه short comment إن الcongestion in heart failure patients we have to differentiate between two types of congestion.
Yes.
Intravascular congestion or tissue congestion. With the problem in the patient discharged from the hospital with residual tissue congestion, this is a bad prognostic parameter because repeated hospital admission and mortality and so on.
Yes.
How to differentiate between intravascular and tissue congestion? Number one. Number two, the biomarkers. أنا يمكن يعني هسألك هل دلوقتي normal BNP in a patient with heart failure أو exclude diagnosis of heart failure?
Yes, if we have a normal value, this means the diagnosis of heart unlikely. يعني I mean
I review the literature. No, and there is a special group of patients with heart failure and the preserved ejection fraction called low BNB deficiency أو the BNB deficiency syndrome. The presence of not elevated BNB does not exclude the presence of heart failure, but even in patients with heart failure with reduced ejection fraction and reduced BNB may be a bad prognostic marker.
Yes.
You don't mention the biomarkers, the adrenomedallin. And my question to you, يمكن comment برضو عليها, how to differentiate between intravascular congestion and the tissue congestion. Number one, therapeutic implication. ده هل في difference في الثيرابي ما بين to relieve intravascular congestion or tissue congestion?
I think for the tissue congestion, if we have a significant impairment of the function, I mean, like in patient having liver impairment or renal dysfunction, I will see that the patient have elevated liver enzymes and have impairment of the renal function, elevation of the serum creatinine impairment or electrolyte imbalance. This is in tissue congestion, if you mean the organ dysfunction. In the interstitial or intravascular congestion, I have to look, I think, the ultrasound in patients with pulmonary congestion. I can see the B lines before the development even of the pleural effusion. So lung ultrasound can differentiate in patients with pulmonary congestion usually precedes the development of physical symptoms and chest X-ray or pleural effusion. So lung ultrasound in pulmonary congestion can differentiate between both the tissue and the interstitial congestion.
We have clinical parameters to detect intravascular congestion. Congested veins, inferior vena cava pleura,
diameter, yes.
The parameters of intravascular congestion. Tissue congestion can be diagnosed by the lung ultrasound, as you mentioned,
yes.
excellently.
Thank you.
The therapeutic implication, we can use loop diuretics for relief of intravascular congestion. However,
yes.
Vasopressin antagonist is preferred for relief of tissue congestion.
Yes.
Some speculate recently a new drug called the monoanticlonal antibodies for adrenomedallin, called adrenosuzumab. And this drug is used for relief of tissue congestion. SGLT2 inhibitors had natriuretic and aquaretic effect, and they speculate that the SGLT2 inhibitors decrease through glucosuria, decrease the blood intravascular congestion.
Volume.
However,
yes.
through increased intravascular osmotic pressure,
yes.
cause aquuresis. One of the beneficial effects of SGLT2 inhibitors in patients with heart failure.
Okay, thank you, Dr. Tare. Thank you so much.
Thank you. It's thank you.